Hi, everyone. My name is Allison, and Seth did a great job of really teeing me up for my presentation here. So thank you for giving us that background on food insecurity. That's exactly why we looked at those statistics to really understand why we wanted to continue to pursue this. I'm not sure. Seth, what did we push? Okay. All right, so as Seth mentioned, we have a lot of our patients in our organization that are faced with making tough choices that affect their health. And when you look at the data, there's many times that our patients are deciding whether or not they should eat or treat. And we're seeing that more and more, especially in some of our rural populations that don't have as many social services as some of our urban populations. And on top of that, as we looked across our clinical outcomes and where we need to focus clinically, we were also recognizing that we were not being as successful as we felt we could be in our type 2 diabetes management, despite the fact that we were putting a lot of resources, clinical resources, wrapped around patients when they came into our offices. We had registered dietitians, MTM pharmacists, we had nurse navigators, everybody was there, community health assistants, to try and give them the best opportunity to be successful. But despite that, we really weren't moving the needle like we thought. And so we took a step back and said, how do we need to think about care differently? How do we need to start to think about care outside of the four walls of the clinic and the hospital? And what is the underlying root cause for maybe why we're seeing this trend? And so we talked about how do we solve the problem. We have a great partner, and I think somebody earlier in the day spoke about the need to, especially for healthcare organizations, to partner with the people who really know how to do this work and the importance of the community-based organizations. So we found a great partner in our Central Pennsylvania Food Bank. We reached out to them and said, hey, you guys have a mission. You're doing a lot of this work already. We're a healthcare system. We don't know a lot about stocking food in food pantries. So how can we possibly work together to create really a prescriptive food as medicine approach? And the reason we decided to take the food as medicine approach is because of the ROI and some of the other things that we talked about. We knew we needed to be able to demonstrate the clinical impact. And so this is a very prescriptive diabetes management program. There's a couple key elements. First is identification. So we have embedded in our electronic medical record 2 food insecurity questions that we ask every patient when they come into our facility. So we're collecting that information from all of our patients. Then we marry that up with our clinical data to understand who has uncontrolled type 2 diabetes and lives in a geography where we have one of our fresh food pharmacies. And then we do a referral. Also, our physicians can refer, our patients can self-refer. We chose to stand up those fresh food pharmacies in geographies within our footprints that had high rates of food insecurity and high prevalence of uncontrolled type 2 diabetes. So we were very intentional with where we chose to stand up those facilities. Our food as medicine approach, a lot of times people think this is in a closet or off the side of somebody's desk. It's actually our most recent facility is a 5,000 square foot facility. It's a self-serve model. So when our patients come in, they're empowered, just like they would go into a grocery store. We have glass front coolers. They can choose their options. We are a choice pantry, and then provide them with the recipes and education that they need. The thing that's very different about our program compared to other similar programs are a couple key things. One is the amount of food we provide. So we provide 10 meals a week, every week, for the patient and their entire household. So it's a significant amount of food provision. We made the decision that if we were doing this as food as medicine, if you give a patient insulin 3 times a month, they're probably not going to be effective at managing their diabetes. And because this is a diet-responsive condition, we felt it was important to provide a large majority of the food. The education and clinical support is also very, very important to the success of our program. Looking beyond their clinical needs to transportation needs and other social determinants, we had a big lesson learned as we went down this path that we needed to spend more time in transportation and some of those other social determinants. And then the community partnerships are key as well. This is just one quick example of one of our patients came into the program with a 13.8 hemoglobin A1C. Through the course of the program has reduced that to 5.4, and with a ROI of $8,000 to $12,000 per every 1 point reduction, it's pretty easy to recognize that providing the food for this patient was definitely worth the long-term benefits. And you can see her other measures decrease significantly as well. We always say that the side effect of our prescriptive medication program is you also lower your cholesterol, you lower your triglycerides and your weight. A couple clinical measures real quick. We are seeing an improved average 2-point reduction. We're seeing better compliance with our care gap closures. We're seeing all those other measures that I just mentioned, and we're also seeing other financial impacts. We're showing a 74% difference in admission rates between our enrolled and non-enrolled population, 27% difference in ED visits, and an increase in PCP visits, which is important. Thank you.